Greetings, everyone. I am Peter Chu, one of the San Diego Organization of Healthcare Leaders Annual Conference co-chairs. And on behalf of the SOHL Board, Annual Conference Planning Committee, and my annual conference co-chair, Johan Otter, welcome to the beginning of SOHL's 2020 Annual Conference, reimagined this year as a multi-day virtual series. Please note that this session is eligible for 1 qualified education credit, which can be self-reported in your American College of Healthcare Executives account. Whether you are attending live or watching the recording, be sure to enter the date of the event as November 5, 2020. For those of you who joined us in October of 2019, the month when our conference is typically held in person in a large and bustling room filled with food and chatter, you may remember that that annual conference focused on emergencies in healthcare. Many of our discussions then seem incredibly prescient now. This year, SOHL's 12th annual conference will gather speakers ranging from senior leaders of multi-hospital systems and federally qualified health centers to frontline nurses and lab technicians. Our aim is to generate discussions that capture the Southern California experience with the global pandemic, what we have learned so far, and how we as healthcare professionals should proceed when planning for the future. It takes a dedicated community and intense local collaboration to provide access to consistent, high quality, and affordable care. And we want our annual conference this year to highlight our strides, progress, and continued work ahead, not only in San Diego, but also neighboring Imperial County. Without further ado, it is my honor to introduce the moderator for our keynote address, Vernita Todd. Vernita is Vice President and Chief Strategy Officer of San Ysidro Health, a federally qualified health center, which she leads in identifying and executing opportunities for growth and development. Prior to San Ysidro Health, Vernita was Chief Experience Officer for Health Center Partners of Southern California, a consortium of FQHCs. She is also a lifetime member of the National Association of Community Health Centers and was inducted into its Grassroots Hall of Fame for her advocacy work. Vernita holds an MBA from Davenport University, as well as a master's in organizational communication and behavior. She is also a fellow of the American College of Healthcare Executives. Welcome, Vernita.
Thank you, Peter, and hello, colleagues. I'm so pleased that you're joining us here today for the presentation. I believe you will be really excited by the news Dr. Young is sharing with us today. So if we'll have just a few minutes, we'll go through our preliminary slides and then we'll get started with our presenter. Next slide, please. Okay, so you see just the folks that are coming in front of you today. My name's again Vernita Todd. I will be introducing Dr. Sheila Young here shortly, and she will provide our keynote presentation. Next slide. I'd like to take just a minute to refer to SOHL's mission, vision, and core values and see how closely they align with ACHE's mission, vision, and core values. And if you just permit me, I'd love the opportunity to read those because I think it's always important for us to remember why we're here and what it is that we are supposed to be doing in our representation as leaders in healthcare. So the vision of SOHL is to be the leading professional membership society for all current and future healthcare leaders in San Diego in Imperial County. Our mission is to advance members' professional excellence and thereby advance the healthcare industry. As one of my favorite authors, Maya Angelou, says, when you know better, do better. And that's what SOHL allows us to do. The core values of SOHL are professional development, networking, innovation, and mentoring. These align heavily with ACHE, with the vision being the preeminent professional society nationwide, the mission of advancing members' healthcare management excellence, and additional core values of integrity, lifelong learning, leadership, diversity, and inclusion. Next slide. I would encourage any of the folks watching us today to consider advancement to fellow. Whether you're just beginning your career or in transition, you can take advantage of all of the resources that ACHE and SOHL has available to help you as you navigate that journey. It is certainly a beneficial designation that allows you to learn a considerable amount as you're studying for that test, but also an ability to work with your colleagues in figuring out ways how to take academic knowledge and put it to work in the workforce. Next slide. So we have to spend just a minute talking about the 3 other learning opportunities that you have available in December. The annual conference series has focused heavily on COVID-19 and what we've learned so far. And the 3 sessions in December will further those dialogues. So on December 1st, we have an executive leadership during COVID-19 from 12:30 to 2 p.m. and all of the different moving parts that impact from the provision of care to leading through burnout and fear and anxiety in the course of a pandemic. The second one, crisis management on December 10th, and then COVID-19 on the front lines on December 14th. In addition to learning a lot about the subject and the ways that you can apply some of these lessons to your own organization, they're also eligible for face-to-face credits through ACHE. And in the year 2020, where face-to-face travel and those credits have been difficult to gain, this is a great opportunity for you to do it virtually. I would encourage you to take a look at your schedules and see which one of those you can join. Next slide. So now that we're in the virtual world, we realize that we're doing business a little differently, and we could not have done this session, the conference, or the number of virtual sessions that we're doing without the dedicated and committed help of our sponsors. There are way too many to list on this slide, but we wanted to make sure that we gave them the proper thank you and appreciation for still supporting the work happening for the leaders of SOHL and ACHE in San Diego County. So thank you to our sponsors. We are grateful for your support and your encouragement, and we look forward to continuing to work with you. All right, so I've gotten all the pleasantries out of the way. It is my pleasure now to introduce you to our keynote speaker. And so I will read her bio for the most part and then hand it over to her. Dr. Sheila Young, welcome. We're so glad that you're here today, is the director of the Charles Drew University Martin Luther King Outpatient Center COVID-19 testing site, which was organized in collaboration with the Martin Luther King Outpatient Center and the Los Angeles County Fire Department, as well as the Los Angeles County Department of Health Services for South Los Angeles. The site has tested 74,000 people thus far for COVID-19, over 1,100 a day, and has provided on-site registration for individuals with and without cars and instructions in both Spanish and English, taking away many of the barriers some of these populations face. Dr. Young is most proud of the fact that CDU students and students from medical, nursing, PA, and Masters of Public Health schools across Southern California completed over 24,000 combined volunteer and clinical hours to get this work done. Dr. Young has worked internationally in developing countries studying healthcare systems and access. Prior to the earthquake in Haiti in 2010, Dr. Young organized a medical mission to rural healthcare center in Haiti, developing cervical cancer screening programs and educating healthcare workers on interventions for protein malnutrition. She was appointed administrative director of a disaster relief hospital on the Dominican-Haitian border and organized over 100 non-governmental organizations, including the Pan American Health Organization, in the care of 3,000 patients and family members. At Charles Drew University of Medicine and Science, she trains underrepresented undergraduate and graduate students to successfully navigate the complex medical school application process and then matriculate into medical school. She lectures and has taught advanced level courses in histopathology, anatomy, physiology, pathophysiology, and clinical skills. She believes that radical improvements in the healthcare system will only occur through education and acculturation of a new type of physician who becomes an expert not only in biological science, but in the equitable leadership and management of healthcare. And with that, it is my pleasure to introduce you to our keynote speaker, Dr. Sheila Young. Doctor.
Hello, everyone. Thank you so much, SOHL, for the opportunity to be here today and to speak with you about my passions. It is truly an honor, and I hope that from this presentation, you will take away with you something that encourages you to do the best you can with what you have. With that, I'm going to share a video with you discussing some of the challenges that we face in healthcare.
My wife, Kira Dixon Johnson, was the closest thing that I'd ever met to a superhero. She made me far better than I ever thought I could be, and she was far better than I ever deserved. We're talking about a woman that ran marathons, that raced cars, that spoke 5 languages fluently. So we were blessed to welcome our first son, Charles, on September 18th of 2014. We always wanted back-to-back boys, and we were blessed to find out that we were going to welcome our second son, Langston, in April of 2016. We walked into Cedars-Sinai Medical Center on April 12th of 2016 with a woman that just wasn't in good health, she was in exceptional health. We went in for what was supposed to be a routine scheduled C-section on what was supposed to be the happiest day of our lives, and we walked right into what was a nightmare. Shortly after the procedure took place around 2 o'clock, shortly afterwards, we went back to recovery. As I'm sitting there reflecting in all this glow and pride of being a new father for the second time, Kira's resting, my new baby is resting, and as I look at her bedside, I begin to see the catheter begin to turn red with blood. I brought it to the attention of the staff, the nurses at Cedars-Sinai. They came in, they said, we're going to do a couple of things. We're going to order a set of tests. We're going to order a CT scan to be performed stat. I was concerned, but I said, you know what? My wife is healthy, and what's supposed to be one of the best hospitals in the world. I'm concerned, but we've got a plan, okay? Blood work comes back, it's showing that it's abnormal and she's hemorrhaging. And they ordered a CT scan that was supposed to be performed stat. Keep in mind, this is around 4 o'clock. 5 o'clock comes, no CT scan. Her blood levels are continuing to drop. By this time, she's beginning to shiver uncontrollably. 6 o'clock, no CT scan. She's beginning to become pale. She's in extreme pain. 7 o'clock comes, 8 o'clock comes, no CT scan. I'm begging, I'm pleading the staff to do something. And around 9 o'clock, as I continue to plead for my wife's life, the staff at Cedars-Sinai Medical Center tells me, sir, your wife just isn't a priority right now. 8 o'clock comes, 9 o'clock, 10 o'clock. They said, well, we need to do a blood transfusion. I'm saying, well, where is the CT scan? It wasn't until after midnight that they finally took my wife back to surgery. After I'd begged and pleaded for them to take action for more than 10 hours. When they took Kira back to surgery, they opened her up and there were 3.5 liters of blood in her abdomen. And she coded immediately. Now I'm here to tell you this. I'm not here to tell you what I think. I'm here to tell you what I know. There are people on this panel that are far more intelligent than I'll ever be that are going to talk to you about the statistics and how horrifying they are. What I'm here to tell you is this, is there's no statistic that can quantify what it's like to tell an 18-month-old that his mother's never coming home. There's no matrices that can quantify what it's like to explain to a son that will never know his mother just how amazing she was. My wife deserved better. Women all over this country deserve better.
In 2018, the United States of America has the highest rate of maternal deaths in the developed world. Every single year, we mourn roughly 700 mothers who are lost to complications during their pregnancy. And at least 350 of those deaths are preventable. Most alarmingly, profound racial disparities persist in these statistics. Black women today are 3 to 4 times more likely to die of pregnancy or delivery complications than white women. Before we try to explain that away on socioeconomic terms, just access to care, access to education, higher income, we have to be clear that even when you control for those factors, a wealthy Black woman with an advanced degree is more likely to die or to have a baby die than a poor white woman without a high school diploma. Black women are 243% more likely to die from pregnancy or childbirth related causes. 243%. There are, as we speak, 20 Republican attorneys general that are attempting to repeal the Affordable Care Act in our court system, after most of my Republican colleagues have voted to do the very same thing more times than I can count. So let's remember, 9.5 million. That is the number of previously uninsured women that gained healthcare coverage, including maternity care, which is an essential health benefit, under the Affordable Care Act. Coverage for women of color grew at more than twice the rate of women overall in 2013 to 2015. So to have a conversation about maternal mortality at a time when our Republican colleagues are using every tool in the book to roll back access to guaranteed maternal care and maternal coverage is a bit much.
Every time I see that video, my heart breaks. Every time I see that video, I realize that Kira Johnson could have been me. I could have been Kira Johnson. I have 2 children. What were the factors that led to her death? Why was her husband dismissed? In our medical training, we know and we understand that if someone has been in surgery, if their hemoglobin levels begin to drop, if we see blood in the catheter, we know that there's likely internal bleeding and that patient has to be taken back to the OR. Where was her medical student? Where was her intern? Where were her junior, senior, and chief residents? Where were her attendings? Why was she not a priority? She had health insurance. She was educated. She was part of a community in Los Angeles that has political influence. Even with all of those things, her life didn't matter. I want us to take a second to look back and consider, how did these elements come into medicine? How did these elements become a part of our subconscious? I believe that these factors are the effects of a legacy of colonialism, ideas of eugenics, and explicit, implicit bias, and frankly, racism. Racism is a disease that must be eradicated in medicine. In colonialism, the goal was to take land, to have individuals conform. Right now in the United States, we know that Native Americans suffer some of the worst health outcomes than anyone else. And the Indian services system is not sufficient to meet their needs. We know that Planned Parenthood initially was designed to decrease the birth rates of not only Black people and other minorities, but also poor white people. So classism plays a part in this as well. I want you to understand that Black people in the United States have lived in fear for over 400 years. This is contrary to the movies you hear, to the music you may hear. You know the statistic that when a police officer pulls up behind a Black person, that Black person's blood pressure raises. Their sympathetic nervous system is essentially activated. Why is that? Even if they've never been pulled over before. It's because that fear was passed down through their DNA and through education on how to stay safe. Let me say this one more time. Black people have lived in fear of their lives for over 400 years. Think about why that would be the case. Let's think back to the times where Black people were enslaved in this country. And it was only a few generations ago. What happened if they didn't do as they were told? What happened if they questioned? What happened if they tried to run away? They were killed. So within the Black culture, you must understand that staying safe, learning how to avoid certain situations, these are the things that are being taught. So again, the ideas that Black people are violent, they're untrue. We're here today to talk about healthcare equity. We know the statistics. And we saw just now how Black women die at higher rates from childbirth than any other racial or ethnic group in this country. My question to you today is, do we really want a healthcare system that is equitable? What would it cost us? I think one of the most important things that we can do is really evaluate this question for ourselves. If we want a healthcare system that's equitable, we have to look inside of ourselves. We have to determine whether the things that we were taught are appropriate. When I was in high school, I did a summer program. and the leader of our program, Marta Serini, made a comment that everyone is racist. And I questioned, am I racist? What have I learned? What do I think about other people? And are those correct? Is that the right thing to do? Stereotyping, determining who's valuable and who's not. It is part of the culture that we live in today. One of the ways that this is demonstrated currently is through our undocumented citizens in California. Yes, I did call them citizens because they live here and they work here. California has the fifth largest economy in the world, not only because we offer such great technology. We feed 25% of the nation. If we feed 25% of the nation, how do we do that? We do that on the backs of undocumented individuals who are paid abysmal wages. This is one of the effects of capitalism, one of the effects of looking how we can continue to gain more at the expense of others. I want us to look again at how we treat undocumented immigrants in this country. Are they important? Do we think that they're not as smart because they don't speak English? Do we think that they're not as valuable? Do we think that they're dispendable? And who gave us the right to determine who is important and who's not? Who gave us the right to say who can live and who cannot? Through my medical education and training in the hospital, it was very apparent which patients received the best care and which ones didn't. Which ones the attending was willing to spend time with, talking about their leisure activities, and the patients that they didn't have time for. We've been trained in medicine to practice racism. It's okay to not talk to a patient and look at them in their eyes. It's okay to not provide the highest level of care. It's okay not to give time to a patient who needs it. So I'm going to ask again, do we really want a healthcare system that is equitable? What I see right now is that we don't. We can have diversity committees. We can have retreats. We can take modules or do modules on health equity, on how to have cultural competency. but it doesn't change our fundamental values or how we view individuals. So what if we're just honest and say we don't? We don't want a healthcare system that is equitable. We don't want a healthcare system where everyone receives the same level of care. We don't want a healthcare system that provides the proper education and medication to their patients. So if we're honest and say that we don't, then those individuals who are left on the outside, on the margins, perhaps they can begin to organize themselves. Yet we would never admit this openly. It's demonstrated subtly. What are the ways that we subtly dismiss people? What are the ways that we subtly prioritize certain people over others? We know that if a patient has a family member who's a doctor, they'll get better care or more attention. We know that if it's someone who's donated to the hospital, they'll get better care, more attention, closer follow-up, longer visits. But is that right? What type of medicine are we practicing? The truth is that we're not. We're practicing favoritism. However, one of the things that's gotten me through my life and all the challenges that I faced is having hope. That we can change. Having hope that if we're provided with the right tools, the right resources, the right mentors, we can change. Would it be too far-fetched to consider an equitable healthcare system? Would it be too far-fetched to provide the same attention and level of care to a congressperson as an undocumented immigrant to the United States? What would it take for us to make that change? It would take us to look inside of ourselves, to be honest with ourselves, to evaluate, why did I not spend time with that patient? Why was I too busy for that patient? Are they important? So when you see a patient who doesn't look like you, or your friends, or your family, will you value them? Will you provide them with the care that they need? We can discuss structural racism, but who is at the center of that structure? It's people. It's the people at the table, the people making the decisions. Is it possible for us to find ways to address these structural issues without having to use a punitive model? If we want to see change in healthcare, if we want an equitable health system, the first way to accomplish that is to change ourselves and value every patient that comes before us in whatever setting we're in, whether it's through street medicine, whether it's in amazing buildings, federally qualified health centers, or county hospitals. You are the person that will drive an equitable healthcare system. Thank you.
Wow, Dr. Young, this is Vernita. Colleagues, please, thank you. What an emotional and powerful plea for the situation that we find ourselves in. I'm back on video. I really do appreciate your honesty and your willingness to have us challenge our own assumptions about where we are and what we do as practitioners, as leaders, as educators, that we all have a role in this process. So thank you very much. I am really pretty touched, and I'm not often without words, but I don't have a ton right now, just as I'm resonating with the thoughts that you just talked about. And one of the things that I was struck by that you asked is, you said, if we're being honest. And I guess, are we ready for that answer? And let me just say it in the context of, election week. I've had many friends who have been very disturbed by what they think the election numbers show us. They thought it was going to go one way or the other way. But as it relates to bias, as it relates to this conversation, the reason why I ask you that is because my friends, I think, got an honest response to a question I'm not sure they wanted honesty to. And in that regard, for us that are in medicine, if I work at an institution, a highly respected institution that answers no, not by their words, but by their action, my question to all of us on this call is then, what are the bold steps we need to take in order to move that forward? And I really would like your opinion. The plea is honest and powerful. And what do we need to do next? So for practitioners, what would you offer as a bold step? For educators in, these folks going through medical school, what would you offer as a bold step? And for us as leaders in healthcare organizations, what would you plead for as a bold step?
Again, I think that the bold step is the internal step. The bold step is looking inside and making a decision and challenging ourselves to drop the incorrect ideas that were passed down from previous generations that we accepted. And acknowledge that they're invalid. I think that we can't make the changes that are necessary until we do that.
I appreciate you saying that, and I'm going to date myself as an old woman, but you know, the young kids are around here talking about stay woke, stay woke, stay woke. And when I hear that, I think, to me, in the context of this conversation, it addresses our unconscious bias, right? So when we have this conversation, implicit, unconscious, the fact is it's happening without us even realizing, without even recognizing. For example, there have been all types of anecdotes that have shown when diverse students are interviewing, even for residency or trying to match, that the interviewer is looking for a common bond. They're looking for a common experience to have a conversation with that person about. And in the instance that they don't, say they're opposite from a person of color or a different culture or religion, what they rely on or fall back on are these assumptions and stereotypes that are in their head, all in the goal of connecting. But in that goal of connecting, sometimes it builds a bigger bridge. So how do we get to, you know, Walt Whitman says, you know, examine everything you've learned and then dismiss what insults your soul, right? How do we get people in the context of race or bias or discrimination to dismiss what insults their soul without then condemning their own soul for feeling it? And I know that's a big, deep, heavy question for you, but when you speak to your colleagues about how to make this better, how to make it different, what are you hoping they will come to know about themselves? What are you hoping they will say out loud to other people who look like them? How do you propose this conversation to begin? Because I believe we will have a lot of dedicated professionals who do want to examine. But then beyond the willingness to do so, need some tools or some opportunity to say, hey, when you get in there, it might be messy. So what would your advice to those folks and your colleagues be?
I think that we have to choose leaders of our organizations who have done this internal work. I have friends from every single culture. I have friends where everyone's blonde and I'm the only person who's not. But they're my friends and I love them because they've done the work. They've done the work of staying woke. They've done the work of analyzing their views. And when something pops in their head, they question it. Is this appropriate? Is this right? And then sharing that information with others. When we say unconscious bias, what we see is mimicry. It happened to me when I was training. I started to develop a sense of, okay, we're here at the public hospital. We can do whatever we want to do because it doesn't really matter if this patient dies or not. And I know that that's hard to admit, but it was something that I started taking on, and I had to catch myself and say, wait a minute, that's not what you value. Just because someone else is doing it doesn't mean that you have to, right? That was a common phrase used when we were growing up. It takes leadership to model what we should do. It takes leadership to praise those who've made that change and made that decision. But if we continue to be taught by individuals who hold values of racism that can be demonstrated not only through words, but actions, through body language, then we're really not going to see a change if they're not in place. I know that it's hard work, but I think we can do it. And the other thing I would say is you have to be willing to give your own self grace and compassion. So if a patient didn't receive the same level of care and you recognize it later, give yourself grace and compassion and say, okay, I saw this. Next time when I'm faced in this situation, I will do better. Medicine is one of the fields where we always challenge ourselves. We always want to do the next best thing. We're never satisfied. So we have to develop that same attitude in this area to address racism. I think that the other thing that we need to do is ensure that there are people of color at the table. That there are people of color at the table who can address some of the issues that someone might miss, or because of culture, not understand that something may be offensive in one culture to someone. And so one of the things that I've done in my life is I've just become a student of learning about other cultures. When I was in high school, volunteering in the ER, I saw my my classmates bring in their family members. And I noticed that their family members had red marks all over their forehead and on their arms. And the first thing that came to my mind was, are they being abused? Right? We don't believe in that. We don't believe in elder abuse. And then I took a step in and I asked, what are the marks? And they said it's coining. It's where you take a coin and you rub, and that's part of the culture. And so now if I see that on another patient, I'm able to understand. I also learned to speak Spanish fluently. And that's something that we can challenge ourselves to do. I learned to speak French. And so when I was at Jamaica Queens Hospital and we'd get patients over from JFK, I could communicate with them in French, or with Haitian patients in Haitian Creole. So if we just took that step to become curious about other people and then see what they could bring to our lives, see what we can learn from them and how they can enrich our lives, I think that that's one way that we can learn to appreciate the diversity we have in our human culture.
I couldn't agree with you more. I think that level of self-examination at the individual level and it is just critical to the care that you provide for patients. We have often heard and share, you know, we have an internal residency program. And so I often, as I'm introducing the health center and our core values to them, as a part of their onboarding and introduction, I always have a quote from one of the founders of Johns Hopkins who says, you know, a good doctor treats the disease, but a great doctor treats the patient with a disease. And so our focus is understanding that we are all unique and we come, you know, with cultural ties and all of the connections that mean something to us as individuals that we all cobble together to make us the person we are sitting in front of you as a physician. And do we want to be treated like you've treated everyone else that day? Or am I looking for some linguistic competency? So there's somebody who speaks French if I speak French. Am I looking for some cultural competency? Someone who's not going to call the police because I'm practicing my tradition. You know, how are we going to not make the problem worse? And so I guess as I'm looking and knowing that our audience is a bunch of healthcare leaders, the institutional part, particularly in training. I once had a student who said, but Vernita, we never learn how to identify these rashes on Black people, because all our mannequins are light colored. So how does this show up on Black people? I will be really honest. I was really excited over the course of 2 weeks to find Johnson & Johnson was making brown girl Band-Aids. And in that instance, I had several of my African-American colleagues who felt I was way too pleased with that level of incremental progress, right? That they want us to make large strides. And so I guess institutional wise, knowing that if I cut my finger now and I don't want you to see it, I can have a Band-Aid that kind of blends with my skin tone. That is a little itty bitty step, but it is a step. And so we as leaders, what are the maybe not bold steps, but the baby steps that we can take to disregard not only our self-examination, but our institutional fields that we put in, or that structures that are in place? How can we start chipping away at them? So if you had a chance to speak to, you know, the large number of healthcare CEOs that will give this a holler, or a COO who's looking for additional ways to improve their organization, or HR managers who are finding ways to incorporate diversity, equity, and inclusion in a way to combat institutional problems. This is your chance. What would you suggest?
The first thing I would suggest is ensuring that the healthcare leaders of those organizations established that in those organizations, they will not tolerate racism, sexism, classism. That's the first thing. It has to be the leaders of the organization who set the tone for the culture of that organization. So if we have leaders who set that tone, we also have to set up an accountability structure. So we have Title IX, right, for sexual harassment. However, if someone brings up an issue of racial discrimination, they're often dismissed, or they're told, you're playing the race card. So what systems do we have in place to report that an employee or patient experienced racism? One thing I haven't brought forward is that we have to acknowledge as well that in medicine, doctors, medical students, pre-medical students of color face discrimination. And so that also is part of the system. So how can we treat our patients with equity if we don't treat those who are training to be physicians, or those who are physicians, equitably? So there has to be some hard decisions made. And again, you have to put in place a system of consequences if people experience racism, and also realize that many people don't bring it forward because they're afraid of the backlash. In medical school and residency, so much is is subjective. And, you know, people can make your life hell, frankly, if you say something or do something. And I think the next thing that has to be done for this is that we teach people, and that we, again, challenge people to determine whether they will make the change. So yes, there could be workshops, but it has to go deeper than looking at the surface level. It has to go deeper than that. And again, it has to come from the top. And so the leaders of the organization will set the tone of the organization. And when it's recognized that someone is doing something that's inappropriate, that there are consequences, whether someone is fired or demoted, those things have to take place. Otherwise, people will continue to feel that they can get away with it.
Well, I appreciate your candor, and what I would share as we close this session out, just in summary, the importance of leadership in determining culture and what is acceptable and what you value as your organization, that kind of full-throated endorsement from the top about what is acceptable and what is not acceptable. For those of you who are watching this, I would encourage you as you go back today to consider a couple of things. One, in many instances, it is not the oppressed who stop the oppression. And in those cases, what you heard Dr. Young say is that, you know, if you are being victimized and you speak about it, then you're often put in a box of playing the race card or doing X, Y, and Z. My question is, when does it become appropriate that we who are not being oppressed speak out? That we see the behavior and the actions of our fellow human as inappropriate, whether or not we personally are being attacked or feel like we are the ones in danger. And so building a culture of social capital, of addressing things that don't connect with our core values, is about building into your organization. It's also about building into a culture of respect and integrity within your organizations, and not just having the people who are hurt by it be the spokespersons of it. So that's one thing I hope leaders would have. And we're out of time, but we did have one question, and I wanted to make sure, because we've got a hard stop. Jessica, can I address this one question? Okay, great. So thanks, Jessica. The question is, are medical schools and residencies aligned with this view of inclusion and new leadership? Are we trying to convince medical schools to do this, or are they aligned and starting to do things differently?
Currently, I believe that they're not. Currently, I believe that there are, again, offices, but the offices of diversity inclusion is usually one person, and it's severely underfunded. And sometimes, again, it's part of the culture. Sometimes people make fun of it. Sometimes people make fun of the diversity modules that they have to take. We have to look at the medical school admissions process. You know, who are we accepting, and how are we evaluating whether they have this value that we are going to care for all of our patients equally, regardless of their income, social class, regardless of the way that they're dressed, regardless of any other factor that would make us practice differently. So
I just appreciate that. And with that, I'm going to have to ask us to close because we are at time and we want to be respectful of the time. As I finish, thank you so much, Dr. Young. I probably have 30 more questions going through my head. I would love to sit down and really talk this through with you about what we could do next. But our time is out and I promised we'd be good stewards of it. So I'm going to turn it over to Peter.
Hi, everyone. Thank you both to Dr. Sheila Young as well as Vernita Todd for today's very powerful session. Thank you for sharing your stories and making sure that we were able to share those also with our membership as well as everyone who will be watching the recording of our keynote address.